Hi guys, welcome to 10 Minutes and to this video on documenting in surgery. Hopefully this will be really useful for your F1 jobs in surgery, which I think nearly everyone has. So without further ado, I'm going to move on firstly to talk about the ward round documentation. So there's this really helpful document produced by Royal College of Surgeons of Edinburgh, which lays out really nicely the perfect surgical ward round. So first of all, don't forget to put patient details on. So that's their name, date of birth, and hospital number. In electronic notes, this may happen automatically, but in paper notes, you might have to remember to always write that down or put in a sticker from the front of the patient notes. This is really, really important, as technically when it's scanned in at the end of the hospital stay, your documentation is not valid unless there's the patient details. Next, we're looking at the date and time and team. So date and time is self-explanatory, but for the team, you'd write which specialty you are. So for example, the upper GI team, and perhaps the name of the consultant leading that ward round on that day. So they've kind of split it up into these 10 different sections. So 1 and 2 is the history, so the title of what the patient has come in with and what the diagnosis is really important. So for example, 19-year-old male that's come in with right iliac fossa pain 3 days ago, diagnosis appendicitis. For the relevant information, you could elaborate a bit more on what that diagnosis is, or for example, if they have any other diagnoses during this stay, for example, a pneumonia post-op, you would write that in that section. In relevant examination findings, this is what you'll be documenting from seeing the patient on your ward round, and you'd also document any discussions and explanations that were had to the patient. So comment on things like, have they opened their bowels? Is it normal for them? Are they passing urine? Are they eating and drinking? And in terms of examination, comment on where's tender, basically do an examination that's specific to that specialty and to that operation that they've had. So for example, in the appendicectomy patient, you'd want to think about whether the abdomen's soft and non-tender, SNT, and whether their scars look healthy and whether the patient looks generally well. So next, for results in 4, we think about the observations firstly. So that's really important to write in for all of your surgical patients, because these will tell you early on whether your patient's deteriorating. So it's always good to have a good look at those. All of them are really important post-op. We've got whole videos coming up on fever in a post-op patient and low blood pressure in a post-op patient. So don't ever forget to write the obs for a patient. They're really important. Next, looking at blood results, radiology results, and urine results. So keep these concise and relevant to the presentation. Write what's important for that patient and what's important for the presentation. That will get easier with time. For blood results, think about the hemoglobin, the inflammatory markers, and the white cells, and also look at the renal function, which often could take a hit post-op. For radiology results, this will often be CTs or ultrasounds. And for urine results, I would often only write that if it's positive. Then you write your differential diagnosis for that day. What is the current diagnosis and what's currently going on for this patient? And then importantly, your management plan. This is how you convey to the rest of your team and your colleagues what's going on for this patient. So in here on the right, we've got some ideas for management plan that aren't always documented that well. For example, always consider VTE status for that patient. Are they protected against a venous thromboembolism? Have we written up their regular medications? Do they have adequate painkillers prescribed? Are they nil by mouth for today as they're going to theatre today or tonight? Do they need IV fluids? Have we handed over to the nurse? And most of all, does the patient understand what the plan is for the day? If you write down a good management plan, I find this really helps you for the rest of the day, as it prevents a lot of questions by family members, patients, nurses, and the rest of the MDT about what's actually happening with this patient, especially with regards to them being nil by mouth or whether they're going to theatre. Next, at the bottom, we've got some extra bits that I also think are really important. DNA CPR status. More and more frail people are being operated on. So have that in the back of your mind and don't be afraid to raise it to a senior if you'd like that to be discussed. You could also comment on boarding status and discharge, which will be very helpful for your nursing colleagues and the hospital team to think about when this patient will be discharged and whether they're suitable to be boarded, so put up in an extra bed in an unconventional place in the ward to help the flow of the hospital. Here are some abbreviations. So I will leave most of these up just for you to have a look at in your own time. But important ones for surgery, if this is all looking very confusing, I would say are nil by mouth, NBM, and soft non-tender, SNT. That's written very often in surgical ward round documentation. Here are some common surgical scars, and I won't talk about all of them in detail. Your midline is possibly your most common, or your gridiron and lance incisions for appendectomies. Phalangeal is something seen more in obstetrics, that would be for a cesarean. And here on the right would be kind of how you document your abdominal examination. And here's some helpful diagrams about how to document if there's a surgical drain and its contents, or a urinary catheter, which I really like. Always think about fluid balance, especially in certain surgery presentations like bowel obstruction, pancreatitis, or where an ileostomy has been fitted. These are situations where a lot of fluid is actually lost. Think about looking at someone's urine output. We'd be aiming for over 35 mils per hour. This is a really good indication of whether someone needs more fluid or not. So think about replacing that in surgery, looking at the electrolytes and prescribing your fluids based on what they need. This fluid chart is very confusing, but looking at the fluid charts would help you theoretically show how much fluid has gone in, how much has gone out. Finally, I've just included a specialty-specific assessment. I've just provided an example here, which is orthopedics. So after an orthopedic operation, you often have to document whether someone's neurovascularly intact. So in terms of the vascular part, that would be commenting on things like cap refill and whether a pulse is present. And here I've included some diagrams for the neurology part. So you'd be thinking about the specific nerves that could have been damaged in that operation, that are often sort of downstream from the operation that you've done, and documenting whether they're intact in their sensory domains as well as their motor domains. So you do those tests on a patient. If you're unsure about any of these, always ask your seniors. They'd be happy to help you. And best of luck for your surgery placements.